Welcome everyone to today's webinar on the topic of Undertaking and Superintending of Pediatric and Adult Population Non-Adherence. We're excited that you all could join us today, and we have what I'm sure will be a fantastic presentation planned for you today. My name is Corey Bryant. I'm the Communications Manager for the Alliance, and I have the pleasure of being your host this afternoon. And we have a few housekeeping items to go over before we get started. For those of you who have never joined us on this webinar platform before, the chat feature is located in the bottom left-hand corner. If you have any questions that come up during the webinar, feel free to submit them at any time. And once the presentation is complete, we'll have some time for our presenter to address as many of your questions as time allows. We are recording this webinar, so we will not be opening the phone lines. That means that all questions must be submitted using the chat feature in the lower left-hand corner. Registration is currently open for our upcoming Get Connected webinar on November 14th. It's entitled My Death, My Decision, My Donation, and highlights two OPOs presenting recent cases, outcomes, and learnings surrounding challenging scenarios with first-person authorization. It's sure to be very insightful, so we hope you'll join us on November 14th, and that will be our final Get Connected webinar for the year. Hard to believe that we're near the end of the year already, but information on our 2018 webinars will be forthcoming, so stay tuned for that. For today's webinar, we are offering 1 CEP-C credit and 1.2 nursing contact hours, courtesy of Iowa Donor Network. Everyone who is listening to today's webinar is entitled to claim continuing education credits. So if you're listening in a group, and I know many of you are, please make sure to get the evaluation email from your group lead. It's a very brief online evaluation which will allow you to receive your credit. And also, one note for nursing, you have 14 days to claim your CE, and for CEP-C, you will have 30 calendar days. So at this point, I would like to introduce our moderator, Unica Sempira. She is the Liver Clinical Manager for the Piedmont Transplant Institute of Atlanta and is a member of the 2017 Alliance Transplant Webinar faculty. Unica, it's an honor to have you with us, and at this point, I will turn it over to you to introduce our speaker.
Good afternoon, everyone. I'd like to introduce Lance Stein. Dr. Stein is a transplant hepatologist here at Piedmont in Atlanta, Georgia, who specializes in liver diseases and transplantation. Dr. Stein's special interests include viral hepatitis B and C, management of complications of liver cirrhosis including portal hypertension, metabolic liver diseases including non-alcoholic fatty liver disease, and health and wellness after transplantation. Following graduation from Temple University School of Medicine, he completed residency in internal medicine at Emory University School of Medicine, followed by a gastroenterology fellowship at the University of California, San Diego. He has also completed a fellowship in advanced transplant hepatology at both Columbia and Cornell New York Presbyterian Hospital. Dr. Stein currently serves on the national committees for the American Association for Study of Liver Diseases, American College of Gastroenterology, and the American Society of Transplantation. His hospital affiliation with Piedmont Atlanta Hospital Specialty, Hepatology, Liver Diseases, and Transplantation, Transplant Hepatology Board Certification in Internal Medicine, Gastroenterology, Transplant Hepatology, and Special Interest for Viral Hepatitis B and C. Dr. Stein, thank you, and you can go ahead and begin.
All right, great. Well, thank you for having me. I hope I do this topic justice because the topic can be somewhat mundane in terms of its title. Where's my slide advancer? Here we go. So we're going to talk today. Thank you, everybody, for taking time out during their busy days. I know you guys step away from patient care to listen to these. So I want to try and make this as useful and entertaining for you as I can. Today we're going to talk about patient non-adherence, right? So very long topic, but really what we're talking about is adherence to medical care, in particular here following transplantation. So I had no financial disclosures regarding this topic. So what you're going to aim to learn today is understanding some of the terminology used in the field of non-adherence, describe the design of a pre-transplant multidisciplinary team, and we can tell you some of the things that most centers are doing in the country and in the world to achieve selection of the appropriate candidates for transplant. Evaluate current post-transplant multidisciplinary care practices as it relates to patient adherence, and then identify strategies that all of us can utilize to ensure that we have the best outcomes for the patient. So I think these types of talks are always good when aligned to a real-world case. So this is one of our patients here at Piedmont. This is a 59-year-old female. At least she was 59 a couple of years ago. I don't know if she is now, but she was 59 at this time. She has end-stage liver disease due to primary sclerosing cholangitis, or PSC. She underwent a transplant in 2009. You're going to hear this word adherent a lot. So she's adherent to visits, was a compliant patient from her first 3 years. And then she lost her health insurance. And as you guys know, what happens a lot of times is patients can be embarrassed when that happens if they can't afford their health coverage. And they sometimes will hide things from us because of their pride. So probably a similar situation happened here, because this is a little unique. She didn't just stop taking everything. She just lost her health insurance and was trying to minimize some of her costs. So she had blood work done once in 2013 that popped up. Everything looked great, and then we didn't have blood work again until she got admitted to the hospital. At this point, we're moving into 2015. So in 2015, she now has new onset jaundice going on for 4 weeks. Her blood work at this time, and like I said, her previous blood work was normal, shows a bilirubin of 6.9, an ALT of 95, and an AST of 68, and her Prograf level was toxic at 23. She reports taking her Prograf yesterday, the day prior to admission, but not the evening prior or the morning of the visit in the emergency room. So that's presumably a 24-hour level trough. So, a couple questions that I was, wondering when you see a case like this is, she has acute hepatitis. Does she have rejection of her allograft? And if it's rejection, would this be chronic or acute? And why does she have a high Prograf level? So a couple reasons why. I'll tackle the third one first. A couple reasons why we will see a high Prograf level in this setting. The first one often is patient behavior, which is patients are trying to save costs if money is an issue with their drugs, and they will split out their medications. And then when they find themselves getting sick from unrecognized rejection, they start to notice symptoms. They start to take more medication. Or what's more commonly happens is they're getting levels routinely, but they're taking lower than anticipated doses, and we're calling them to tell them to increase their dose, which they don't, so their levels remain low. And then when they feel sick, they start taking the dose that we last told them to take, which makes them toxic. So the other scenario, which is probably more likely here, which is this is a patient who we believe was adherent to her medication, just wasn't adherent to getting labs performed or coming to clinic appointments, is that she has liver allograft dysfunction, and her liver is involved with processing the Prograf, and the dose of Prograf she has is now inappropriately high for her and causes her to be toxic. So to determine whether she had rejection or not, a liver biopsy was performed. You can skip right down to the second bullet point here, which says these findings are consistent with post-transplant autoimmune hepatitis, not rejection, with evidence of advanced fibrosis, early cirrhosis, with liver decompensation, also noted clinically where she had ascites and jaundice. So here's some thoughts I kind of just jotted down that would typically go through a provider's mind when thinking of these types of patients. This patient was taking her medications. Therefore, it proves that she's compliant. She was doing what she was doing what she could, given that she had some financial challenges. In this setting, she had no health insurance. Though luckily, this particular patient was actually getting her medications. She lost her health insurance coverage, but had this backup plan where she was still getting coverage for her medications. I forget the situation. It was a little bit unique, but she had access to her medications. Or you can argue the transplant team must have failed her. It's our fault. We should be following her labs and routinely, and when she didn't get labs routinely, we should have identified sooner and intervened sooner. And you can only do so much for these patients, and I know a lot of that was done. Phone calls are made, letters are sent, but patients have to take ownership for themselves. Or the system failed her, right? There should have been some sort of backup for her, where when these situations happen, where she lost insurance, there's the ability for financial coverage to get her reinstated back on her plan, or to get her involved in the insurance market. So I think this all happened around the time of the first year of Obamacare. It might not have been an option at the time. Or she failed herself, right? She should have been open with us. She should have been honest. She should have recognized that there was a problem, that she wasn't able to have her laboratory data per our protocol, and therefore unable to get her routine health screening. She should have let us know that that was a problem, and we probably would have been able to work something out. So what is compliance? And important to differentiate compliance from adherence, and I'm going to switch officially into using adherence into the rest of this talk after mentioning compliance here, but compliance is the word that we tend to utilize. We're just utilizing it inappropriately. So compliance, by definition, I just copied this directly from dictionary.com, so comes from the Latin word complere, meaning to fill up and to complete an action, transaction, or process, and to fulfill a promise, all right? So essentially, you are acting in accordance with or yielding to a desired, request, condition, direction, consenting to act in conformity, adding practical assent. So, I mean, when we say compliance in the clinical term, that's kind of what we mean, but the word adherence is actually a little bit more exact. So adherence means to cling to or to keep close, to remain constant. It also means to be persistent in a practice or attendant with maintenance. And I think that's really, in the medical term, a better word for these patients. All right, so the title of the topic was also to include pediatric populations, and we are an adult center, so I don't get much pediatric patients. So this is pretty much 50% of the pediatric exposure of this talk is in a photo right here, which has nothing to do with the words, but there it is. So adherence is a better term for healthcare, like we talked about, because it talks about patients' active participation in their care. So what are some of the factors leading to poor adherence? Well, we know some of these. They're obvious to us, but they may not be obvious to all of us, and they may not be obvious to the patients and their family. So regimen complexity is a big one that is particularly unique to transplant. So the number of medications, the changes in medications, the frequency of administration can be very complex for patients. Patients also only have the amount of health literacy that they have. So health literacy is a term in regards to a patient's ability to understand medical terms and medical care and navigating the medical system. Obviously, physicians and nurses would have the highest health literacy if they were patients for themselves. And you can expect very smart people don't make good decisions when it comes to their own health care. And part of that is because they don't have good health literacy despite being literate. It could be the failure of the patients, or in the pediatric population, their parents, to understand the benefits of being adherent to therapy, and this relates to the case that I described. There's poor communication by the healthcare team. Often we communicate poorly to patients who communicate poorly to us, right? There's this transference and counter-transference, and we don't always recognize when we're actually being counterproductive to our own patients, sometimes in the words that we choose to use. And also, the biggie is there's a lifestyle change that is necessary to accommodate a diagnosis that has a treatment plan. And I think we're all used to this in something as simple as having to go to the dentist every 6 months for a tooth cleaning. Not all of us will make that sacrifice to make the lifestyle change, which is to leave work for 2 hours, or to go to work 2 hours late, or to leave, or to take a day off to accommodate that. That can be problematic for certain people, and therefore we're not adherent to routine dental hygiene in some cases. So in terms of health literacy, the Affordable Care Act, Obamacare did implement some terminology into this. So it's part of the government's aim is to ensure that we are communicating in a way that is acceptable to all patients. And what their choice of words was, to define this as the degree to which an individual has the capacity to obtain, communicate, process, and understand basic health information and services in order to make appropriate health decisions. right? So it's a very comprehensive term that makes a lot of sense, but in practice, we're not all doing it. And we're not all doing it for every patient. And then health literacy has its challenges, and that's why we're not doing it. There's a problem with some patients having a lower education level. They just don't get it. And it's not their fault. They're just not educated to the level to understand the language that we're trying to convey to them. Some patients have a foreign language as their main language, or English as a second language, and they may not understand the cultural intuitions that we're often using, or just understand what we're saying to them, period. Even with the use of interpreters in the clinic or language line, there can often be the miscommunication and a misconveyance of what we're trying to say. There can be culture problems, right? So different cultures interact differently with healthcare providers. There's some cultures that are often very subservient, I would say, where they just say yes to everything even if they don't understand. And that's not really helpful for us, because if they're saying yes, our culture tells us that means they get it, but they may not. And then also we sometimes have trouble, physicians and nurses, communicating with our own patients in plain English. There's a default to often use some of the medical terminology. You know, I find myself pretty good at talking in plain English, but even every once in a while, probably on a daily basis, I catch myself using medical terms that I shouldn't be using. You know, in the world of liver disease, a medical term that is so common and rolls off the tongue that is probably meaningless to most of our patients would be something like ascites, right? You know, hey, Mr. Smith, I see you got fluid on your belly again. I'd like to increase your Lasix to help you treat your ascites. And it just kind of rolls off, and you just say it without thinking, because these are the words we're using every day. But there's a good chance he doesn't know what ascites is, and therefore that entire last sentence I just said was meaningless to him. So there's a lot of words on here, so I'll try to get through this a little quickly, but I pulled this off of the NIH and some of the government healthcare websites of what the government identifies as some of the health literacy challenges and some of the directions we should be taking, all right? And this is the guidance they give to healthcare professionals. Don't blame the individual for misunderstanding information that's not been made clear to them, right? So when I use the word ascites, it's, you know, I didn't make something clear. Everyone, no matter how educated they are, is at risk for misunderstanding health information, right? And it's because maybe it's not something they understand. If it's a healthcare professional who's the patient, you know, even me sometimes, if it's not my specialty, I just don't understand what they're talking about. And also there could be the problem where something could be emotionally charged and extremely complex. So when it comes to emotionally charged, we see this a lot in hospitalized patients where we're talking about you know, changes in care or potential end of care or life-threatening illnesses. Families and patients can suddenly start to misunderstand what we're saying because they're so focused on the emotion of the problem. In most cases, healthcare professionals try and believe they are communicating accurately, and that's correct. I mean, I don't think we all have great intentions or all trying to communicate well, but a lot of times, like I said, we're not. Patients may believe that they have patients may believe they have understood directions, but may be embarrassed to ask. And we talked about a little bit with the culture, so it may be a cultural thing. It may be a pride thing. They might just not be willing to tell you they don't understand because they want you to be happy and they want you to move on with your day, which is obviously not in the best interest of themselves. Healthcare organizations have a significant role to play in ensuring understanding, right? So this is a mandate from the Affordable Care Act to ensure that healthcare organizations are also playing a role. And some of this is actually policy, right? That's part of what these accountable care organizations are. As we move forward to different payment models for medical care, some of this is also going to be captured. A lot of this has been movement into the EMRs because the EMRs have patient instructions all built into them that you can provide to patients at time of visit. There are reimbursement strategies by some of the private insurers, such as Kaiser. I know Blue Cross has a program to work with certain disease states to pay for phone nursing care to help navigate patients through complex disorders, things like diabetes. Inflammatory bowel disease has a similar program. You know, some of the private insurers have transplant nurses that are employed by the insurance company to help, interact in this exact way, because it's in the insurance company's best interest to keep these patients well and healthy and out of the hospital. It's difficult for people to separate evidence-based information, especially online, from misleading ads and gimmicks. Basically, this is a lot of words for saying don't Google shit, because when you Google shit, you get in trouble, right? And this is what our patients do. They go online, they Google, they get confused. I don't know if you've ever tried to Google a medical illness. It's a little complex. It's hard to know what's real and what's not real. You often end up on some website of an unhappy patient somewhere who tells you the worst case scenario. It's not an ideal place to find medical information. The communication of risk in an effective and fair way continues to be a challenge. We talked about that, that's obvious. The challenge is in how to select insurance plans and benefits, especially for those who have not been previously insured. And this is obviously a new problem that was created with the Affordable Care Act and on the online exchanges. I don't think there's any doubt all of us, particularly leaning on our social work staff and some of the financial coordinators, have had difficulty navigating patients to get the appropriate plan. And we're only seeing a small portion of the patients that are out there. We're not seeing anywhere near the millions who have to make these decisions. And they have to make decisions about high copays or high deductibles and terms of coverage. And sometimes these are sick people making these decisions. Sometimes these are healthy people who have yet to be sick and may get sick in the next year. These are complex things to do. I can tell you, I know when I go online for open enrollment for our health care, I'm always a little bit confused, right? I mean, and I always believe that I'm confused, that everyone else must be confused too, because these are medical things that are not easy to navigate. So the World Health Organization also has a kind of a risk classification for who's at risk for non-adherence. So there are socioeconomic factors. The biggest one is going to be age. There's nationality, employment status, whether you're married or not. There's financial situation. There's education. There's disease status, such as smoking, alcohol abuse, depression, bipolar disorder. There's treatment-related factors, patient symptoms, side effects of medications. Right? We all know patients take a medication or two and stop because of side effects and don't always tell us. Again, often they think they're going to hurt our feelings. And then the healthcare system often is a risk factor. Well, what about for transplant, right? So spent a lot of time, and we really haven't mentioned transplant yet. So there's a lot of data out there in regards to transplantation and adherence. The vast majority of it comes from the kidney transplant world, and for obvious reasons, most transplant data comes from kidney transplantation in regards to solid organ, because number one, the burden of disease is higher, and number two, there's 2 kidneys to give away, right? So more patients are able to get transplantation with end-stage renal disease rather than, say, pancreas transplant, heart transplant, liver transplant, and lung is just not as many organs available, even though, of course, there are 2. So for adherence, when it comes to transplantation, being older has a better prognosis or more likely to be adherent. Being a woman, and we know that's true, right? Being Caucasian, having good social support, having a good insight into illness, positive perception of treatments, education, absence of psychiatric illnesses, good rapport with the physician and the patient, simpler medicine regimens, right? We know daily medicines is better than twice-a-day medications, medicines with lower toxicity, comprehensive healthcare coverage, access. Sometimes this is distance to the healthcare center. We know that patients who live further away from our transplant centers tend to have higher rates of non-adherence. For some reason, diabetics tend to have good adherence when they're older. Not always the case when they're younger. There's some conflicting data about diabetes. And, of course, the window from transplant, we often have good adherence early on, and then lifestyle changes can happen, kind of like our patient case, and that can lead to lack of adherence down the road. In regards to medications, I pulled this out of some just generalized adherence papers I was reading. So it's kind of this full circle, right? You have to understand the medication. You have to organize it. You have to organize your brain to want to take it. You have to monitor the refills and monitor the taking. You have to sustain it for a long period of time. And then you have to go back and fill it again, right? It's this full circle. Understand, organize, take the medications, monitor, sustain. And there's a lot of places in there for patients to fall off the adherence wheel. All right, so what about transplant immunosuppression? So don't look at these numbers as mantra. I think the general gist to take from the non-adherence rates is that the non-adherent rate is higher in kidney transplant than it is in heart transplant and liver. It tends to be quoted, depending on the paper, around 10 to 35% for kidney transplant. It tends to be around 5 to 15% for heart transplant, and it tends to be around 5 to 15% of non-adherence for liver transplant. Now, if you define non-adherence as one episode of non-adherence, meaning they didn't come for their monthly lab test in the first year of transplant once, then the rates start to increase to much higher levels. This is really a behavior, a repetitive behavior of non-adherence. And some centers in some of the earlier data have reported that the risk of dying of liver transplant, that 1 in 10 of their patient deaths is actually related to non-adherence. Now, you may not recognize that right away, but if you start to delve into your patient deaths that you will find at your transplant centers, a lot of times you will find that these deaths are often a result of non-adherence to something. So it may be that they came to every appointment. It may be that they were taking their medications appropriately, but it may have also been that they didn't take their lab tests routinely, and therefore there was an opportunity to intervene maybe on a problematic rejection or a problematic opportunistic infection earlier than was actually intervened, and that infection may have led to death. Now, we know this is an obvious statement, the title here, kidney transplant, non-adherence leads to poor outcomes, right? That should be intuitive, but we didn't know that was true, right? But there's a lot of data out there, particularly newer data, suggesting that kidney transplant recipients who don't take their medications, don't follow up their appointments, don't take their laboratory testing, actually have markedly increased rates of graft loss. So this one I pulled out of MUSC in Charleston, looked at a whole bunch of their recipients. Half of them had a documented non-adherence episode at least once. Half their patients, right? And then of those who had at least one documented non-adherence had a 40% increase odds of acute rejection over those who are adherent, and a multiple-fold increased risk of further rejection episodes. And then they took this as another study, or published this just this year, but it was presented at the same meeting. The other paper was showing the importance of actually coming to clinic, right? We're willing to bend over backwards for our patients, for those who have travel difficulties, right? This is a common scenario, particularly those patients who live more than an hour from the transplant center. They just can't get to clinic. They don't have the money for the gasoline. They don't have a ride. They don't own a car. Whatever the reason is, it happens, and we've all had these patients. This paper looked at, well, what happens to those patients? So they looked at over 4,000 kidney transplant recipients. They pulled the data from this National Renal Data System. They also looked at patients who were transplanted in the veterans clinics. They found that about 15% of the patients had a no-show rate of over 12%. Okay, so they didn't do what they're supposed to do over 12% of the time. And then if they had appointment non-adherence, then they had 1.5 times the risk of acute rejection and a 65% increased risk of graft loss. Okay, just by being the type of non-adherent patient who doesn't come to clinic. Those with appointment and medication non-adherence together were at a very high risk of graft loss compared to only those with an appointment non-adherence or those with only a medication non-adherence. And I think the reasoning for something like this is that when they come to clinic, there's an opportunity to intervene, right? Real world examples. When our patients come to clinic at the first 2 weeks, at the first month, at the third month, at the 6th month, during those visits, they're often seeing some of our ancillary staff, not just the advanced practice provider and not just the physician. They often will see the PharmD, sometimes a social worker, and we'll capture with multiple people walking into the room that some of the things that the physician thought were happening actually aren't. Patient may be taking medication incorrectly. A lot of times the physicians don't ask all these questions. We just look at the medication list, we see on the medication list, we assume it's being taken because the nurse said it was. But then the PharmD walks in and finds out that, the patient was taking Prograf daily, not twice a day. And why is that? Well, maybe it was just misunderstanding. Maybe it was a typo on the discharge summary. But a lot of these things get found at the appointment. And that's where that face-to-face time really is key to identify potential problems. This was another survey. Emory here in Atlanta was involved with this in a couple centers in Chicago, looking at 99 consecutive kidney transplants who were willing to come back and do and consent to a formal interview. So what they found was that 24% of the participants had limited actual literacy. So you can imagine what their health literacy was. Patients took on average 10 medications, so you're taking patients at risk and giving them complex regimens. And not only that, you're making it challenging for them by changing their medications frequently, which is what we do in transplant because there's appropriate times to adjust medications. 32% of them had a change within the last month from this interview, and this interview could have happened at any point post-transplant. It wasn't early post-transplant patients. On average, though, most of them knew what their medicines were and what they were for, and most of them were able to demonstrate proper dosing of their medications. But 35% were non-adherent, either on self-report or by measuring their Prograf levels. And when they looked at the risk factors for what was causing some of this, the fewer months from transplant, so they were early, they didn't have enough education, I guess, limited literacy were the risk factors for non-adherence. In addition, patients with being of a minority race, having the higher number of medications, mild cognitive impairment, also led to lower treatment scores. So here's my other 50% of the pediatric portion of this talk, which is I had to find something pediatric that was somewhat interesting, and this was kind of adults, right? They're 17-year-olds in some of these cases, but they looked at all of the pediatric heart transplants that were performed in the country between 1999 and 2007. And they found that then they looked at all the kids that were non-compliant, so 186 of them, that's almost 10%, were non-adherent in terms of their follow-up appointments. And then of those, 48 of the 186 died within a year of receiving their transplant, and 61 of those patients died within 2 years, which were markedly elevated compared to the adherent population. And of these patients, the vast majority were the tweens and the teens, so age 12 to 17. We all know that teenagers are invincible, right? But, part of it's got to be the parents' fault too, right? And some of the other additional risk factors of being Medicaid insurance, we can't change that. Having an LVAD, so they were sicker patients, and also having African American race. So what are some of the interventions that we utilize to help ensure that our patients are going to have non-adherence and therefore lead to the best possible outcome for our transplant recipients? Well, it all starts at the time of the initial consultation and follows through with their transplant evaluation, right? So we always advise that patients bring their families to the education and meetings that we have set up for transplantation, because it helps bring into patient selection, right? We lean on the physicians and the nurse practitioners and PAs, the transplant nurse coordinators who meet these patients, the social workers who weigh in on their support, their financial their home life plans, the substance abuse. I mean, the social workers really, in transplant, often are behaving like psychologists. We rely on our nutritionist, our psychiatric staff, and then I even threw in here ancillary medical staff, because there's been many times where we have, the inpatient nurses who get involved in these patients' care, or the laboratory personnel who will help identify problems or risk factors patients might have that maybe we weren't noticing, often with the problem patient, right? And then you can start to work with patients or to select out who you think won't be a compliant, sorry, use the word compliant. See, even I got in trouble. Who won't be an adherent patient. So the opportunities to intervene is education, education, education. We try and educate these patients as many steps along the way. We are fairly strict, at least at Piedmont here, about ensuring that our patients actually attend all of the education sessions that we offer before transplantation. I think where we get into trouble is sometimes patients do truly live far, far away, and they may not be able to come to them all. We try to bunch it with them or do a web-based version. Or the more likely scenario is they got rushed into transplant because they came and met us for the first time when they were very sick. So all of the usual safety net that occurs in the outpatient setting never had a chance to be achieved. We do patient mentorship with some of our prior transplant recipients to coach and educate patients. We do outreach with them. Outreach occurs more commonly in the kidney transplant side, working with the dialysis centers. There's a collaborative approach with all of the healthcare providers as well as the patients. Financial counseling gets involved because that becomes a big deal with insurance changes. We will do proactive chart reviews on our patients. So if we notice the patient has missed a lab or didn't show up to an appointment, we'll contact the patient and see what the issues were and make sure they get seen in a timely manner or reroute whatever was intended. And then again, ultimately, a lot of what we do is candidate selection. But despite candidate selection, there's been plenty of studies that physicians are not good at determining who will be adherent to a medical therapy. There's just no good test to determine if a person sitting in front of you will be able to follow instructions and do as you instruct them to. So there's this thing called the AIDS method, which it can help promote adherence. You can read this on your own time, but assessing their medications, individualizing the regimen. I think we all do, the physicians do a really good job of doing this, but I think we could all do a better job. Providing written communication, educating them and continuing to educate them whenever possible, and then supervising. And I think the PharmDs, at least at our center, do a really good job of helping with the supervision. There are a lot of post-transplant interventions that can be done, and these are really important for those patients who may be rushed into transplant. And again, education, education, education. At least here in our center, we do education sessions prior to discharge. I imagine every transplant center does these. And we sometimes will repeat them if there's a sense from the teachers or the nurses doing the teaching that there was limited understanding or that another family member needs to be taught. Well, then we'll do a second session prior to discharge. Nursing intervention. We have phone calls made by the nurses to the patients early after transplant. Those patients who have access to home health care visits, those can always be helpful, but they're usually only limited to those who have substantial needs, physical needs usually. And appointment reminders can be helpful. In the transplant population, not everybody's adept with the computerized electronic versions that we're utilizing now, but appointment reminders, however they're done, usually telephone call, is extremely helpful, but a personal phone call can be extremely helpful, particularly to bring patients back to remind them. And then medication reviews ahead of time, medication reviews at time of visit, medication reviews after. The more you review and talk with patients about what medicines are on, the more likely they are to be adherent. And then utilizing technology can be extremely helpful. So education has been shown to be very important. We do this because we think it works, but there's actually been people who've looked at whether it works or not. So there was this group in India at a liver transplant center that looked at a systematic pharmaceutical educational protocol that they teach to help improve the patient's understanding of their medications. And they did a pre and a post test score, and they found that their non-adherence rate after instituting this dropped from a high number all the way down to 4%. This is something I just Googled looking for phone apps for medication adherence, and one that popped up was a transplant-related one. Now, I don't know if we're using this at our center, to be honest. I know we utilize this medication online version where patients can go in and plug in their medications and adjust it. And then, our EMR has a patient interaction, but not every patient utilizes these. But most patients do have smartphones. This is something here where it will give you phone reminders to take your medications, can give you reminders for refills, and these kind of tools probably are going to be another thing that we can utilize, to minimize patients falling off the track. So what do we do here at Piedmont? And Unica, I'm sorry if I'm missing some of the things that we do. I was just thinking through this last minute and just putting it down along the steps of the way. We do our best to give education at every visit. We involve our social workers from the beginning, and then we re-involve them early on, and they're pretty good about self-identifying patients at risk, and they will find them and hunt them down and come and see them at the follow-up appointments, even post-transplant. Pre-transplant enrollment in a safety net foundation, and the reason why I even say that is in Georgia we have something called the Georgia Transplant Foundation, which is a great thing that's been available to us, and it is a financial it releases some of the financial hurdles that patients may have. Patients will do fundraising, and then funds are matched. It will help cover post-transplant medications. It will actually help cover insurance premiums for some patients. They'll help cover travel if patients have a travel need to help them get their transplant care. And it's really great for when patients have a switch of insurance and they find themselves underinsured in the future. We work to identify issues and work through them, and this really leans on our excellent RN providers who are doing post-transplant care. We give formal pre-transplant education. Obviously, they get that again post-transplant at discharge, and then we do post-hospital phone calls, the pharmacist we talked about, and then another layer is utilizing a specialty pharmacy. So we utilize a specialty Walgreens here, is really good about managing transplant medications. Like I said, some of the insurance plans are really good about reaching out to patients. We utilize the EMR, right, to find missed appointments or when there's delays. We utilize Phoenix here with our EPIC program, which has been a nice benefit. And then we do a review once a week of some of our complex post-transplant patients, and often we end up reviewing in a team approach some of the non-adherent patients. So again, everyone's in the room, nurses, social workers, physicians, and we can help identify patients in need and see if anyone has additional strategies that maybe haven't been covered that can be utilized to help the patients in need. So back to our original case, and I think I'm doing perfect with time, huh? So our clinic staff worked with this patient to help guide her back into enrolling in a health insurance plan. Her medications were able to be continued to be covered, and she was getting coverage by the Georgia Transplant Foundation, I believe. And then, re-educated her and her family about the need for follow-up. Her repeat labs that just popped into her medical chart 2 days ago. Her LFTs remain a little bit abnormal, but her bilirubin has now normalized. Her liver function is completely recovered because her problem was actually she was developing liver failure again from autoimmune hepatitis, and all that she needed for treatment was to have a tuning up of her immunosuppression. All right, great. That is it. Thank you.
Well, thank you very much, Dr. Stein, for a very insightful presentation. So before I turn it back to Unica for questions, just as a reminder for everyone, if you have questions for our presenter, let's go ahead and advance the slide here. You can please submit them using the chat feature in the bottom left-hand corner of your screen. And during the Q&A time, I will also have this poll up. For those of you listening in a group, please complete this poll and let us know how many people were listening in your group. So at this point, I will go ahead and turn it back to Unica to moderate our questions.
Okay. I am waiting for a couple of questions, but I know some of the post coordinators and pre-coordinators here, questions that they often come across is what else can we do as coordinators, and what type of power do you give them to be able to address those issues that aren't shared? because sometimes it's done secretly or you don't know that it's being done. What other options do they have other than just being referred to social work?
You're asking me to answer that?
Yes.
Yeah, so, what do we, so I guess let me see if I can rephrase it. So what do we do with the high-risk patients other than leaning on social workers?
Yes.
Yes, I mean, really the first line of defense is the social worker, but because the social workers are really good about identifying what the needs are and avenues to help satisfy those needs. But, I know it really depends on what the individual situation is. A lot of transplant's unique in the sense that with the medications there are well-funded foundations to help with medications. What we tend to do from a financial standpoint, if there's a financial need beyond medications, is we can work with the hospital to help try and get some of the visits covered under charity care. We can work with some of the local providers. We can give them information if they qualify for Medicaid to start enrolling for Medicaid. Nowadays, we will punt them towards the financial advisors, the financial coordinators who can give advice on enrolling in private health insurance and which plan might fit their needs the best given their transplant. So, that's a tough question to answer.
Okay. Next question I have, should we start a program or should there be a program started that's geared towards pre-transplant patients to prove compliancy?
So that's a challenge, right? Because I mentioned that physicians are not great, and I imagine if physicians aren't great, then all of us aren't great at identifying who is likely to not be adherent to therapy. So I guess the question is saying, should we test them before transplantation and therefore, identify who's going to be not adherent and then maybe work with them to ensure adherence or decline transplant listing for that patient? That's a tough question, right? So, one of our main aims as a transplant program is to offer transplantation to as many people as possible, to give everyone the benefit of the doubt and to help people, right? And I worry that when you do things like that is that you start to select out patients who maybe otherwise probably would have been good transplant candidates. I think this happens naturally anyway. I think there is a lot of patient self-selection away from transplant. I think, when we review our discussion patients at the end of transplant selection, and, a lot of it is, I'd like to send this patient a not a candidate letter because they haven't been coming for their appointments or they haven't been getting their blood work. Those are the obvious ones. But the ones who come to appointments, those are the ones we generally will transplant. I think where we struggle, and this is a reality, are the ones who come into the hospital sick and get transplanted on that hospital admission. And that's a very common scenario in the world of liver transplant. Probably a common scenario in the world of heart transplant too. It's not that common in kidney transplant. It actually probably never happens.
Okay. And then kind of piggybacking on your response to that, I've got another one. How can we address the patients that are emergently transplanted to improve knowledge and compliance?
Yeah, so what we do here is we try and make it quote-unquote mandatory that they come to some of the education sessions after the transplant, even though they've already been transplanted. But you can't really force anyone to do anything. You can't physically bring them in, so it becomes a challenge. I don't know if anyone has any bright ideas out there. This is not really an interactive session, but I'm sure there are some strategies that can be done, but I think just relying on the safety nets that are built within the transplant center, and once you identify those patients, is to work with them. But yeah, it's a challenge.
Okay. I haven't gotten any other questions. data.
All right. Well, if there are no other questions, we can go ahead and conclude today's webinar. I'd like to extend our thanks once again to Dr. Stein and to Unica for your time and for a fantastic presentation today. To all of our participants, thank you so much for your time, and we wish you a wonderful rest of your week. Take care.